We are now more than halfway through 2026, and if you have been paying for prescriptions through Medicare since January, there is one number you need to check today. $2,100, not next year, not during open enrollment, today, because once your qualifying out-of-pocket spending on medications covered by Medicare Part D reaches $2,100 in 2026, you should no longer owe co-payments or co-insurance for those covered Part D drugs for the rest of this calendar year. But here is the problem. Many people are adding up their pharmacy receipts and assuming every dollar counts. It may not. Your premium does not count. A medication outside your plan's coverage may not count. A drug billed through Medicare Part B follows different rules, and if you paid cash without the claim being processed through your drug plan, that payment may not appear in the total you are watching. So before you pay another expensive prescription bill, I want you to check exactly where you stand, because you may be much closer to the limit than you realize, or hundreds of dollars further away than your receipts suggest. Stay with me, because near the end I will give you a 5-minute Medicare prescription check that you can complete before your next pharmacy visit. Let's make the rule completely clear. If you have Medicare prescription drug coverage, commonly called Part D, your qualifying out-of-pocket spending for covered Part D drugs is capped at $2,100 during 2026. Once your plan records that you have reached that amount, you automatically enter catastrophic coverage. At that point, you owe no additional copayment or coinsurance for covered Part D medications for the remainder of 2026. This protection applies whether you receive drug coverage through a separate Part D plan or through a Medicare Advantage plan that includes prescription coverage. You do not need to complete a special application after reaching the cap. Your plan should move you into catastrophic coverage automatically. Now listen carefully to the wording. Covered Part D drugs. That is the part many people miss. The $2,100 limit is not a ceiling on every Medicare expense. It does not stop your Medicare premiums. It does not cap doctor bills, hospital costs, dental expenses, or every medication you happen to purchase. It applies specifically to qualifying out-of-pocket spending associated with medications covered through your Medicare Part D plan. Let me show you why this matters. Linda is 72 and takes several medications. 2 are inexpensive generics, but 1 is a costly covered drug with significant coinsurance. Since January, her plan has recorded qualifying out-of-pocket costs of $450, then $380, then $520, followed by several more expensive refills. In July, her recorded total reaches $2,100. Beginning with her next covered Part D prescription, Linda should owe no new copayment or coinsurance for the remainder of 2026. She still needs to present her insurance card and fill the prescription normally, but her cost sharing for that covered medication should be $0. That could protect Linda from hundreds or even thousands of dollars in additional prescription costs between now and December. But she must continue paying any required plan premium, and the medication must remain covered and processed correctly through her Part D plan. Now compare Linda with George. George pays $10 or $15 per month for 2 generic medications. His total prescription spending may never reach $2,100. Medicare will not require him to spend $2,100 simply because that is the maximum. The cap is a ceiling, not a deductible, and not a required annual charge. George continues paying only the amounts required under his plan. That distinction matters because some people hear $2,100 limit and believe Medicare will make everyone pay the first $2,100. That is not how it works. You may pay far less. The protection becomes especially valuable for people who use expensive brand name or specialty medications. Your Part D plan may still have a deductible. In 2026, no Medicare drug plan may set its deductible above $615, although some plans charge a lower deductible or no deductible. Under the standard Part D benefit, after meeting the deductible, a member generally pays 25% coinsurance for covered generic and brand name medications until qualifying out-of-pocket spending reaches $2,100. However, individual plans can structure their copayments and costs differently, so your pharmacy charge may not look identical to your neighbor's even when you take a similar medication. Think of your drug coverage as 3 stages. First comes the deductible stage, when you may pay the covered cost until your plan's deductible is satisfied. Next comes the initial coverage stage, when you pay the copayment or coinsurance required by your plan. Finally, when qualifying spending reaches $2,100, catastrophic coverage begins, and your additional cost sharing for covered Part D drugs drops to 0 for the remainder of the calendar year. Simple enough, right? But this is where 4 expensive mistakes enter the picture. The first mistake is adding your monthly premium to the $2,100 total. Your premium pays for maintaining the insurance coverage. It is separate from what you pay for covered prescriptions, and it does not disappear after you enter catastrophic coverage. If your plan premium is $40 per month, you must generally continue paying that $40 even after your covered drug cost sharing stops. If you owe an income-related adjustment or a late enrollment penalty, those amounts are also connected to your premium rather than your covered drug out-of-pocket cap. So do not sit down with your bank statements, add 7 monthly premiums to your pharmacy receipts, and conclude that you have reached $2,100. Check the qualifying amount recorded by your drug plan. The second mistake is assuming that anything purchased from a pharmacy counts. Every Part D plan has a drug list, also called a formulary. It may place medications on different tiers and may require prior authorization, step therapy, or quantity limits. If your doctor prescribes a medication that is not covered by your plan and you simply pay the full cash price, do not automatically assume that payment has been credited toward the $2,100 cap. Imagine that Robert is prescribed a new medication with a cash price of $310. The pharmacist tells him his drug plan is not covering it at the moment, so Robert pays cash because he does not want to leave without the medicine. He keeps the receipt, but he never contacts his plan. 3 months later, he has spent $930 and believes all of it is bringing him closer to catastrophic coverage. But if those purchases were never properly processed as covered Part D claims, his plan's recorded total may tell a very different story. Before paying cash, ask one direct question. Will this purchase be processed through my Part D coverage and credited toward my qualifying out-of-pocket total? When a prescription is not covered as expected, contact the plan and the prescriber. There may be a covered alternative, a prior authorization requirement, or an opportunity to request a coverage determination or formulary exception. If you already paid out of pocket because your coverage information was unavailable or the claim could not be processed, save the receipt and contact the plan. You may be able to receive reimbursement or have an eligible amount credited towards your out-of-pocket costs. Do not stop or change the medication on your own. The goal is to correct the insurance issue with your plan, pharmacist, and prescriber, not make an independent medical decision. The third mistake is confusing Part B drugs with Part D drugs. Many medications you pick up at a retail pharmacy are covered through Part D, but certain medications administered in a physician's office, infusion center, or hospital outpatient setting may be covered through Medicare Part B instead. The $2,100 Part D limit does not automatically cap the amount you owe for drugs billed under Part B. For example, Mary receives an injected medication at her doctor's office and also picks up 3 prescriptions from her neighborhood pharmacy. The pharmacy prescriptions may be processed under Part D and move her toward the $2,100 cap. The office-administered medication may be billed through Part B under a separate deductible and coinsurance structure. Mary cannot simply add all 4 medication expenses together and assume they belong under the same annual limit. Ask the provider or your plan, is this medication being billed under Part B or Part D? That one question can prevent a great deal of confusion. The fourth mistake is forgetting that the cap follows the calendar year. If you reach $2,100 in July, August, or September, catastrophic coverage protects you for the remainder of 2026. But on January 1st, 2027, the annual calculation begins again under the limits and rules that apply for 2027. You may again face a deductible, co-payments, or coinsurance. That means someone who pays nothing for a covered Part D drug in November or December could see a significant charge when filling the same medication in January. That does not necessarily mean the pharmacy made an error. The new calendar year may have reset the coverage stages. Now let's talk about the number you should check today. Do not rely only on a pile of pharmacy receipts. Each month in which you fill a prescription, your Medicare drug plan sends you an explanation of benefits, often called an EOB. This is not a bill. It summarizes your prescription claims and costs. Review it for errors and look for the section showing your current drug coverage stage and year-to-date out-of-pocket amount. If something does not match your records, contact the plan. Pause this video later and find your most recent EOB. You may receive it in the mail or be able to view plan documents online. Then ask yourself 3 questions. First, what qualifying out-of-pocket total does the plan show? Second, which recent prescriptions were included? Third, are there any pharmacy purchases missing from the claim summary? Suppose your plan says you have accumulated $1,760 by the end of June. You then pay $220 for a covered prescription in July. You may be only $120 away from the cap. That means one additional qualifying refill could move you into catastrophic coverage for the rest of the year. But suppose your receipts total $1,760 while your EOB shows only $1,100. That difference needs to be investigated. Perhaps some purchases were premiums, non-covered medications, discount card transactions, out-of-network claims, or charges billed under another part of Medicare. Do not guess. Call the number on your plan card and ask the representative to explain the difference claim by claim. Also check the pharmacy you are using. Medicare drug plans may have in-network and preferred in-network pharmacies, and your costs can vary depending on where you fill the prescription. Some out-of-network purchases may require you to pay the full cost and then request partial reimbursement from the plan. A pharmacy that is convenient is not necessarily the pharmacy that gives you the lowest cost under your plan. Now, even with a $2,100 annual cap, the timing of your costs can still hurt. A retiree living on Social Security may know that annual spending cannot exceed the cap but still struggle with a $500 or $600 prescription bill in a single month. The Medicare prescription payment plan can spread qualifying out-of-pocket Part D costs across the remaining months of the calendar year. Participation is voluntary. All Medicare drug plans offer it, and there is no fee to participate. Instead of paying the pharmacy when you collect a covered prescription, you receive bills from your health or drug plan. But this program does not reduce your total drug cost. It changes only the timing of your payments. You must continue paying the plan premium, and if you reach the $2,100 cap while you still owe an existing payment plan balance, you must continue paying that balance even though no new covered drug costs are being added. Because we are now in late July, joining the payment option today is different from joining in January. The cost is spread across the months remaining in 2026, not indefinitely. Contact your plan and ask what your estimated monthly bill would be before enrolling. For someone expecting a large prescription charge soon, the option may protect emergency savings from one sudden hit. For someone with small co-payments, it may add unnecessary complexity. Now let me give you the 5-minute prescription check I promised. First, write down every medication you take. Include the exact name, dosage, quantity, and refill frequency. Do not write only heart medication or diabetes pill. Your plan's pricing depends on the exact medication and form. Second, compare that list with your plan's current formulary. Check the tier and look for prior authorization, step therapy, or quantity limits. Third, check your most recent explanation of benefits and find your qualifying year-to-date out-of-pocket total. Do not estimate it from memory. Fourth, call your plan if any prescription or payment appears to be missing. Keep your pharmacy receipts until the issue is resolved. Fifth, compare pharmacies and ask whether you qualify for extra help. Extra help can lower Part D expenses for people with limited income and resources, and many eligible people may not realize assistance is available, and do not throw away the information you collect. Medicare open enrollment begins October 15th and ends December 7th. During that period, you can compare your current coverage with available options for 2027. Your plan can change its premium, deductible, drug list, pharmacy network, and cost sharing from one year to the next. Before open enrollment begins, organize your medication list, pharmacy information, EOBs, and actual yearly costs. The cheapest premium does not always produce the lowest total cost for the drugs you take. Coverage selected during open enrollment generally takes effect on January 1st. So here is the complete rule I want you to remember. In 2026, once your qualifying out-of-pocket spending on covered Medicare Part D drugs reaches $2,100, you owe no additional copayment or coinsurance for those covered Part D drugs for the rest of the calendar year. But the words around the number matter: qualifying, covered, Part D, calendar year. Your premium continues. Non-covered prescriptions may not count. A cash transaction may require follow-up. Part B medications follow different rules. The payment plan spreads costs but does not erase them, and the annual total resets when the next calendar year begins. So before paying another large pharmacy bill, check your explanation of benefits. Find the total your plan has recorded. Confirm that the drug was covered and processed under Part D. And if you believe you have already reached $2,100, but the pharmacy is still charging a copayment or coinsurance for a covered Part D medication, call your plan immediately and ask how the claim was processed. Do not let $2,100 become a headline you heard once but never used. For someone taking expensive prescriptions, understanding this protection could keep hundreds or even thousands of dollars inside the retirement account where they belong. Tell me in the comments, how close are you to the $2,100 limit, and has your plan clearly shown you the amount that counts? This video is for general education and is not individual medical, insurance, legal, or financial advice. Never stop, replace, or change a medication without speaking with your prescribing healthcare professional. This is Olivia, helping you protect your money, understand your Medicare benefits, and make smarter financial decisions after 60.